queries that you have. So it's a real privilege. So without further ado, I'll just load up my slide deck. So as mentioned, my name is Jatinder Minhas. I'm a clinical academic, so I work 50% of my time as a consultant caring for patients that suffer acute stroke within Leicester, Leicestershire and Rutland, and 50% of my time I research within the University of Leicester as a clinical associate professor, trying to improve outcomes for patients that have brain bleeding specifically. I am fortunate to be funded by the Stroke Association as a senior clinical lecturer. That started in February of this year and will continue for 5 years. I have some perspective on not just stroke, but I guess also the challenges that our communities face with access to healthcare, and also specific challenges around risk factors in healthcare as well. Obviously, being from a South Asian community myself, having friends and family, but also, I guess, caring for patients that present primarily to University Hospitals of Leicester. So what do I think it's helpful to cover today? Well, I want to cover what is stroke and the types of stroke that people can suffer. I'm going to talk about some of the risk factors and provide a bit of specifics around ethnicity, and also talk about some of the treatment options. And particularly, I think it's pertinent to understand why we do what we do within the early phase of somebody having stroke symptoms, and why it's absolutely imperative that people get to hospital as quick as possible. And I hope to just provide a little bit of information on that, and hopefully these are things you'll be able to disseminate to friends, family, and others. So what is stroke? Well, it's quite clear to me that there is a long history of trying to understand sort of what the origins of stroke were. And actually it goes all the way back to Hippocrates, who really was the sort of father of modern medicine and described many of the things that we understand today. And what he observed was this people being struck down by lightning, by a sudden violence. And that led to them having some sort of immediate sudden loss of either arm function or leg function. And it was this immediate sort of lightning type effect that prompted him to think, well, what is going on? What is this apoplexy? And it wasn't till really several hundred years later that there was a beginning to be of an understanding that, well, maybe this is to do with something within the brain blood vessels. Is this something to do with bleeding within the brain? And it wasn't until a little bit later on that a German physician managed to conclude that perhaps sometimes bleeding within the brain tissue causes these stroke symptoms. And in terms of the causes of stroke, well, we know a lot about this because in Boston, back in the early 1900s, there was a lot of post-mortem studies that put together some of the risk factors that people had, and most of them were high blood pressure. And when they looked at the type of stroke they'd had and they followed back to the risk factors, they concluded, oh, okay, this was probably people that had really badly controlled blood pressure. But they also did some post-mortem studies and looked and said, actually, there's a lot of different types of stroke, and perhaps we don't know the full story yet. So really, a lot of what we know about stroke is actually as recent as the early 1900s. So it's fascinating to think how far we've come. So what's the state of play in the UK? Well, at the moment, we have around 1.2 million stroke survivors within the United Kingdom. Clearly, there's a spectrum of disability that 1.2 million people will have suffered, some perhaps with fairly minor symptoms, some with major disability. And clearly also, stroke doesn't necessarily spare younger or very older people. It covers the spectrum of age. And actually, we're seeing a burgeoning number of people within the working age or middle age that are suffering stroke. And it's purported that in the next 20 years that the estimated number of stroke survivors aged 45 or over will increase by 123%. So this is not a problem that's going to go away. This is growing. And one of the really challenging things that I experience when I see these patients 3 months or 6 months after they've unfortunately suffered a stroke, there are some things that really affect them. And the three things that I think are really challenging, which we don't have good treatments for, are that a third of them will experience depression. So their stroke will cause low mood symptoms that's really challenging. And actually, standard treatments for depression are not strongly evidenced, particularly in stroke. So we need to begin to think about better strategies there. A third will experience aphasia, and aphasia is a loss of speech. It's a very disabling symptom. If your stroke affects your dominant hemisphere where your speech center is, this can affect speech, and that can be really disabling for people, particularly, if you're an individual that perhaps has a strong social connection, you tend to engage with people. Perhaps your job involves you needing to speak, maybe on the phone or interact with people. And obviously, friends and family, it can be really disabling. And the last is really lethargy and fatigue. It's really challenging symptom. People say, well, I just can't do, doctor, what I used to do before. And unfortunately, we certainly see this 6 months after. We probably see it up to 12 to 18 months after, where people just can't quite get to that energy level that they had before their stroke. And this is perhaps even middle, younger age people in the 40s and 50s. They can't do what they did before. So what actually happens when somebody suffers a stroke? Well, there's a complex network of blood vessels that sit within the brain. And this is the circle of Willis. And it's sort of the control center of all of the various brain tissues. And the blood flows from the neck and both on the sides of the neck and the back of the neck up into this area here. And this is a really precious area of blood flow because all areas need to be functioning to supply the brain tissues. And if a stroke were to occur, which is essentially a blockage of one of these blood vessels, or indeed bleeding from one of these blood vessels, then we unfortunately get some damage to the brain tissue. Okay? And what that looks like is that this complex network of blood vessels sits within the brain tissue. So this is a view from the bottom of the brain. And you can see here that it's intertwined really carefully within these precious brain tissues, which is the sort of beige area that you could see. The blood vessels flow in the red area. And obviously right at the bottom here, and I'll just pop my arrow over, hopefully you can see this. This is the brain stem. This is the real control center of the brain. And you can see here that blood supply disruption here, strokes in the brainstem, really can be quite devastating quite quickly. Okay. Now, the reason that many people have different types of symptoms associated with their stroke is because the brain is a really complex organ, and different parts of the brain govern many of the different capabilities that we all have. Some of them will have really intricate effects on our personality, our perception of the space around us, our vision, our balance, our coordination. And so, for example, you can see here, if your stroke affects the front part of the brain, you're probably not going to have any balance problems which relate here to the back of the brain. But perhaps if you're mainly affecting the front, you might have some issues, for example, with your speech, or perhaps a change in your personality or your ability to solve problems, complex mathematics and things. Or perhaps if it's within the memory area of the brain or the language comprehension. I've seen people that unfortunately forget to be able to speak one of many languages they can speak because the brain has affected a center where they perhaps used to speak English very well. And actually, now they can only speak the Hindi or the Punjabi because the English center, that depth and granularity of their speech is affected. Okay, so the brain is so when people perhaps report having differing symptoms for their, doctor, I predominantly had visual problems, or friends and family say, well, actually my stroke's fairly minor, it's just affected perhaps a bit of my coordination, I haven't had any effect on my balance or other things. This is the explanation for that. Okay, that it depends on it anatomically where the stroke has affected. Okay, now this is a very busy slide. And I think Pushpa's making a few notes on my screen. But what's important here is that, unfortunately, strokes have an associated mortality and morbidity. Okay, so some people will die from their stroke within 30 days, and some people will suffer some disability. Some people actually will have a fairly minor stroke syndrome, and this table is essentially to demonstrate that there are differing types of strokes dependent on how much of the blood flow is damaged. Okay, and that's simply all I'm trying to convey here. Okay. So most of you will be well aware of the Face, Arms, Speech, Time campaign that was administered by the NHS Public Health Authority in an effort to get people to recognize that time is brain, okay? Recognizing the facial weakness, has a person's face fallen to one side? Are their arms weak, so they can't necessarily raise them above their shoulder area? Is there a change in their speech? If so, quickly get to hospital. Now, a key question I often get is, Doctor, do you have to have all of these symptoms? Absolutely not. If you have one in isolation, that may be enough for you. That should be enough for you to think, is this a stroke? Okay. Particularly in somebody that's had a stroke before, or particularly in somebody that's got risk factors for stroke. Okay. So please don't delay. It's important one accesses the healthcare that you need quickly, and I'll explain exactly why in a second. So 85% of strokes are caused by a blockage in a blood vessel. Okay, so before I talk about bleeding strokes, let's park that aside for a second. Almost 9 out of 10 or 8 out of 10 strokes are a blockage in a blood vessel within the brain. Okay, and so that's the most common type that we see. And the main cause is blood pressure. Okay, blood pressure is a real risk factor for stroke. It's the single most important risk factor. And the idea of one knowing their numbers, know your blood pressure. If you're certainly if you're 40 years and over, you will have been called, or between the age of 40 to 74, you should have a free NHS health check, and part of that will be a blood pressure check, amongst many other things. Know your numbers. Okay, it is as simple as, and if you don't take any other message away today, then the one message I want you to take is a small change in your blood pressure can cause a massive reduction in your stroke risk. Okay, if your blood pressure on average is 150 millimeters of mercury, if you lower it down through either treatment, change in lifestyle, many other factors that your GP will be able to advise, down to an average of 140 millimeters of mercury, you reduce your stroke risk by 25%. Okay, this is so important. All right, so if your blood pressure is high, it is not acceptable to be permissible in that context. Please either take some readings at home. It costs, pre-inflation, it was £8. Post-inflation, somewhere between £15 to £20 for a blood pressure machine from Boots or any other available providers. And take one reading breakfast, one reading lunch, one reading dinner for 7 days. Okay, that's what your GP will ask you to do in order to safely prescribe some blood pressure tablets. And even if you've actually got hypertension and you haven't had it checked for a while because the pandemic has destroyed your relationship or access to your GP and it's really tricky, just get those readings and email them in. Email them to your GP. Send them in. Give them a call and say, can I have the email address? I'm sending in some blood pressure readings. I'd like the GP to review them. Okay. 10 millimeters of mercury drop in blood pressure reduces your stroke risk by 25%. Okay. That's the key message from today, please.
Hello.
Okay. So the reason that high blood pressure is a problem is because it essentially runs at such speed through the main vessels. It keeps hitting the walls, particularly in the neck. And if it hits the walls in the neck where there's junctions, it causes these plaques, okay? And once these plaques build up, it's a real problem because blood flow can't get through to the brain very easily, but also the plaques break off. And if it breaks off, where's it going? It's heading up towards the brain, okay? And that's what often causes blockage type strokes. So blood pressure shears the vessels, it hits the vessel walls. So get that blood pressure down. And the reason that we want people to come to hospital quickly is because if you have a blockage type stroke and you present to hospital after 4.5 hours, so that's after 4.5 hours of the symptoms starting, we cannot give you a clot buster because it's not licensed. Okay. So you have your stroke symptoms. There is no time sometimes to wait 4 or 5 hours for an ambulance. If you're able to get into a vehicle and come to hospital, that's feasible. Come straight away. Okay. The ambulance system is often stretched. Sometimes it can take an hour. Sometimes it can take 3. If you're able with a relative to get into a vehicle and come to an emergency department as quick as you can, do that, because if it's a blockage type stroke and that 4.5 hours has been elapsed, we can't give you the clot busting medication. Okay. And so your next question is, well, what does a clot buster do, doctor? Well, if you imagine there's 100 people here, if you get to hospital quickly within that first, particularly 3 hours, but any time up to 4.5, around 30% of the 100 people that get this drug will get back to how they were before their stroke. Okay, so that's 1 in 3 will potentially have disability minimizing treatment at the front door of the hospital. The ambulance service, or even if you come to the ED desk, they will tell us straight away. We'll be down with you in the department within minutes, and we will organize a scan of your brain. And if we don't see any bleeding, we will give you a clot busting drug. But it's so dependent on the public realizing that time is brain and getting to hospital. Now, as with many things in clinical medicine, there is always a risk. And the risk here is that somewhere between 1 to 3 people may suffer some bleeding. Okay. Most of those people will not know about that bleeding because it would just be seen on a scan done at 24 hours. Some people may have some fairly significant and very, very rarely catastrophic bleeding within the brain or within the GI tract, i.e. through the gut. But the key question here is to just make sure that you understand that to give yourself, your relative, your friend, the best possible chance of being able to access this treatment, you've got to get to hospital quickly. Okay. All right. Don't hang around. Don't have tea. Don't have dinner. Don't go around your friend's house. If you have those stroke symptoms, come straight to hospital. Okay. Now, if you were perhaps, if you presented between 8 a.m. to 6 p.m., Monday to Friday, or 8 a.m. to 12 p.m. on a Saturday or Sunday, and even if you were outside the 4.5 hours, or perhaps you were still within the 4.5 hours, but you have a certain type of stroke where that clot is actually sitting there in a big vessel, we may send you to Nottingham for treatment called thrombectomy. Now, this is one of the real kind of success stories of stroke care. When you have a heart attack, you may or may not be aware people can go in your wrist or through your groin to the heart, put a stent in or pull the clot out. They are now remarkably able to do that with the brain. Okay. It's a fantastic intervention that we have got access to for certain hours here by referring people to Nottingham. Okay. You still come to us and then we refer you to Nottingham, and that's called thrombectomy. But again, that's just for a blockage type stroke. Okay. But the key message here is time is brain. Every minute that goes by that your stroke is untreated, you lose 1.9 million neurons. Okay. Almost 2 million neurons for every minute that you are not getting the treatment that you need for your stroke. So time is brain. Okay? That's summary point 2 today. Okay. Lower your blood pressure by 10 millimeters of mercury, reduce your stroke risk by 25%. Point 2 is time is brain. Okay. Now, my particular area of interest, and I think it's somewhat the sort of forgotten part of stroke care, which is sometimes a little bit sad to accept and say, but things are getting better, is that rather than the 8 in 10 that have a blockage type stroke, 2 in 10 have a bleeding type stroke. Okay, so instead of a blockage, it's blood within the brain. So the blood vessel doesn't block, it rips and bleeds. Okay, and that's called a hemorrhagic stroke or a bleeding type stroke. Okay. Now, brain bleeding is associated with a high mortality. Okay. At 1 month, 40% of people don't survive. So if you have a brain bleed, 40% of people don't survive. And this scan shows some bleeding here. So the white area is the area of bleeding within the brain tissue. And unfortunately, that is, it's present there. It will eventually break down, but it's somewhat of a challenge. Okay. And the problem is that these individuals are left with quite significant disability, and there aren't really the same types of treatments that they have, for example, for blockage type stroke, where we can give a clot buster, we can go in the groin and pull out the clot. If you have a bleeding type stroke, there aren't any fast moves at the moment, other than doing very simple things like trying to lower their blood pressure once they're in hospital. If they're on a blood thinner, we can give them some medications to try and reverse that blood thinner. Sometimes they may need surgery, and we, again, from Leicester, we send up to Nottingham for that surgery. Okay. But there's a lot of problems that can happen when you have a brain bleed that are slightly more distinct from those that have blockage type stroke. So seizures are quite common, pressure within the brain, fluid builds up. So I'm just going to talk a little bit about that to give you an idea as to why bleeding type stroke is such a challenge. So some people that present with their bleeding type stroke at 3 hours, so they come into hospital, we scan their brain, we see this bleeding and it's there, and we think, okay, it's not too big, but unpredictably at 6 hours, through no fault of anyone's own, that blood expands. And it's absolutely devastating. We don't have an explanation why. And you can imagine that you perhaps go from being reasonably awake with a potential good outlook at 3 hours. At 6 hours, it's devastating. And often we're having some quite difficult conversations with families. And this is something that we just scientifically don't know a lot about. We don't have any specific treatments for. We are trying at the moment, we're running a trial to see if a medication that sometimes works for people that have heavy periods, or other things called tranexamic acid, whether that may help. And that's an international study run out of Nottingham. But at the moment, we don't have a specific treatment to help for this. And the other problem is that fluid builds up. Okay, fluid builds up around the bleeding, and it's angry fluid. It's really angry and sometimes takes a couple of days to get better. So it's a really different entity, bleeding type stroke. And the other problem is sometimes the blood is in the wrong place. It goes into where the fluid circulates in the brain, and it's in the wrong place. And that's really devastating because the pressure builds up really quickly. Okay, the brain does not have enough space to accommodate it. So when you get to hospital, we recognize a type of stroke. If it's a blockage stroke, we give you the clot buster. What do? Well, we try and get you to our stroke unit. And the stroke unit is the specialized place to care for patients that have stroke, okay? And if you're cared for in a stroke unit, this was a Scandinavian study that was done, it helps your survival, and that pays forward even up as far as 10 years, okay? So your care at the time of your stroke leads to better survival in the longer term. And why is that? Well, it's because you get doctors, nurses, occupational therapists, speech and language therapists, dietitians, all who have a focus on stroke. They know about challenges of stroke care, and they can do this effectively. Okay, so it's really important that we get patients to stroke unit. We try and get them up, ideally within an hour, but almost certainly within 4 hours. But obviously there are delays at the moment due to numbers attending. But we try to get you up quickly. So just moving on a little bit further now. So what about if you're a South Asian person, what specific things do you need to worry about in terms of stroke? Now, there's an absolutely fantastic Stroke Association document, which there's a link here, and I probably will provide that afterwards to colleagues as well to share around. And it essentially is a focus document for us, for South Asians. And it tells us a little bit about some of the things that we specifically have challenges of within our community. And it's sometimes that we're not just hypertensive, we're not just diabetic. These things tend to associate in multiple numbers. So you have multiple risk factors. Other things that are relevant are, for example, things like Barn and Gutka and other things that people smoke or chew, or other things that are particularly relevant to our communities that have a stroke risk. But the key thing is that managing your risk factors like high blood pressure, diabetes, and high cholesterol is really important. And actually, that's perhaps more so because South Asians that suffer stroke don't do as well as their Caucasian counterparts. And one of the hypotheses is that when you compare a same age-matched Caucasian to a South Asian with exactly the same perhaps degree of diabetes or hypertension, for example, high blood pressure, their brain suffers a lot more furring. And the furring for this person within the brain is in this yellow area here. Okay, this is where the furring is, and this raises your stroke risk. So if you've suffered for high blood pressure, diabetes, and other things and it's not been that well controlled for maybe 1 decade, 2 decades, 3 decades, this causes this furring in the brain. And this is perhaps more aggressive and disproportionate in South Asians than it is in other populations. Okay, we get this fairly aggressively, and it causes a stroke risk. So it's quite important that we really do get on top, know your HbA1c, know your cholesterol, know your diabetes, know your blood pressure, and get it under control. Okay. So the next thing to think about is, what are the challenges that people who have suffered a stroke face when it comes to not just them but their families, and some really interesting work around health inequalities, and actually the fact that people who care for others that have suffered stroke, they really don't necessarily have a good experience. They struggle to access the right resources. They don't have a lot of satisfaction with some of the available support groups and networks that are available out there. And actually this is my experience as well. So I do some research, and I like to speak to patients and their survivors about questions that are important to them, and to see whether my research is relevant. And I visited a group that are based initially in Braunston, and there were no South Asians that attended the group. I went away and I did the London Marathon to support the group with my father. This is me and my father for the Stroke Association. We provided them with some funding for some new premises in Glenfield. And I visited the group about 18 months later, really nice new setup. And I saw 3 South Asians there. Okay. And I think what the group was able to do was to perhaps provide a bit more advertising, a little bit more understanding as to some of the populations they weren't accessing from the ward, or perhaps through word of mouth. And I hope that it will continue to grow from strength to strength. But we don't necessarily have at the moment the right face-to-face support groups for both carers and their patients. And I think this is something that, I hope to work with Kirit and others on in our region to be able to better understand the landscape. Okay. So in conclusion, stroke is common and it can be devastating. Okay. Disability and mortality, and certainly bleeding type stroke particularly, is associated with a high mortality. There's been a lot of progress made, particularly for blockage type strokes. But as I mentioned, bleeding type strokes therapies remain limited. Risk factors are crucial to manage, and I can't express that enough. If you have high blood pressure, try to be as aggressive with it as you can. Get your GP, hospital physician, and others engaged in trying to lower that blood pressure. Know your numbers if you don't know any of your numbers at all. 40 plus, you can access that free health check in the NHS. And lastly, I think the key thing here is, if you are unfortunate enough to suffer a stroke, the key thing is to engage with the medications that you're provided with, because what we want to prevent after you've suffered a stroke is a recurrent stroke. Okay. Somewhere in the first 48 hours, it can be as high as 1 in 2 are at risk of having a further stroke. But actually in the coming 30 days, 1 year, it's really important that we try to continue to get on top of your risk factors. And so if you have friends and family that have suffered stroke, the best thing you can do for them is to encourage them to be compliant with their medications, and to continue to keep an eye on their blood pressure, diabetes, and cholesterol. And that should be done annually by the GP. But as we all know, it can be a challenging landscape in primary care, and so I think having some ownership as well is important. Okay, so I will stop there, and I look forward to answering any questions.